Hello guys, welcome to our channel. Today we are going to discuss about the ophthalmology revision video, and those who haven't watched the Sureshot series 150 plus topics, please do revise that video, and high yield topics are included. At least 50 to 60 MCQs are going to be appear in the examination, guys. And also all 19 rapid revision programs also uploaded in the YouTube channel. Please do watch them and revise those topics. It's very important for you guys to score more than 200 plus. Our goal, and we have achieved all rapid revision the Triple R Edition 2 high yield topics, all the important PDFs I have uploaded. Please do revise and use wisely. Okay, this is going to help you a lot. Okay, let's move on to our today's discussion, ophthalmology rapid revision. So first, we have to see the normal structure of the eyeball. So you all think that what is the shape of the eyeball? It is basically aspherical. Okay, it is basically aspherical, and almost 5 to 6 ml is the volume of the eyeball will be consisting. Okay, and eyeball, we all know it is present within the orbit. Orbit consists of the four walls. In that orbit, you have to understand what is the thin, okay, and what is the weak. So the thin will be the medial and weak is the floor. So that's why the floor is more prone to the fracture. Okay. And next, coming to the eyeball, eyeball anatomy. So eyeball has the three important layers, right? The outermost is the cornea. Okay, this is the outermost. And next, inside the middle one, we have the uvea. Okay, uvea is the middle one, which consisting of the this especially here you can see these conditions like a iris, ciliary bodies, choroids, that all will be coming under the uvea only. Next, innermost layer is the retina, right? Retina, which will be producing the whatever the cones, rods, vision, color vision, night blindness, everything will be coming from the rays that is passing on to the retina only. Okay, next, moving on to the cornea. Cornea have very special importance for the cornea here is cornea have specific layers. Okay, cornea have layers. So first, the outermost layer is the epithelium, which will be avascular. So these, even though if anyone get damaged, so it is not going to give any type of the regeneration. And what is the epithelium that is covered here? This is non-keratinized. This is non-keratinized squamous epithelium. Okay, squamous epithelium. And this squamous is the stratified squamous, guys. Okay, it is stratified squamous epithelium. Alright, next, another important thing about this one is the after the epithelium, we have the Bowman's layer. We have Bowman's layer. Okay, Bowman's layer is also an acellular layer. Okay, here also the scar formation will be seen. Next, stroma. Okay, in the stroma, you will be contents of the keratin sulfate. Okay, glycosaminoglycan, and also there will be collagen. What is the collagen that is present here, guys? Type 1. Next, Duas layer. Duas layer is discovered by our Indian, and this layer is considered as a very strongest layer. Next, Descemet's membrane. Okay, Descemet's membrane, the regeneration is seen. So here there will be regeneration that is seen. Next, last one is the endothelium. The last one is the endothelium, and it has maintains the corneal transparency. It maintains corneal transparency. Okay. Next, how much is the diopters that is present here for the cornea? It is the diopters that is present here is the plus 43 to plus 44 diopters, which will be present for the corneal power. Okay. Next, these are the important layers. And coming to the nerve supply. For the nerve supply, we have facial, okay, facial nerve, and also trigeminal nerve. Okay, trigeminal. Trigeminal is going to be the efferent, so which is brings the signal, and facial is going to be efferent. Okay, so this is the nerve supply for the cornea. Next, moving on to the diseases, we have the two important that is the myopia and the hypermetropia. Okay, so when we talk about the myopia, this is actually the image is forming in front of the retina, and hypermetropia is forming behind the retina. So curvature and the refractive index in the myopia patients will be increasing, and here in the hypermetropia patients it will be decreasing. Okay, next, how can we correct these patients? By introducing the concave lens. Okay, we are going to introduce the concave lens, and concave lens is going to correct. So this is how we are going to bring the image for the patient to near. Next, hypermetropia, we are going to focus the with the convex lens. So this is how we are going to and arrange the lenses for the patients of the hypermetropia patient. Okay, next, moving on to the astigmatism. Astigmatism is nothing but it is going to be the double vision, and it can be mixed types and simple types also. The simple myopic, the error is at here. Okay, so the patient is suffering from the myopia and also astigmatism. Simple hypermetropic, same as here, the retina is forming, the image is forming behind the retina, same as the astigmatism. And compound myopic, both errors will be double in this patient. Hypermetropia also double, the patient will be having the double effect of the normal astigmatism and the compound astigmatism. Mixed type, the one patient one of the defect is myopia and other defect is the hypermetropia. And here you can see this is known as a Strum's conide. Okay, this is known as a Stumps conide. And how we are going to see this Stumps conide? This is the normally image is going to follow. And here completes our retina. So how the different types of the astigmatisms are present. So here we are going to check the patient with the Stumps conide. Okay, nothing but these defects we are going to look into the Stumps conide image. Next, moving on to the accommodation. Accommodation is for the near vision. So to the near vision, how we are going to produce. So whenever you are going to look at the nearer object, your lens and your ciliary muscles, journals, all has to be work together. So for example, according to the Helmholtz theory, he tell that whenever you are watching the nearer object, your ciliary muscles are going to contract and your journals is going to relax. So when the journals are relaxed, what happens? The tension of the lenses become rounder. So this is how you are going to look at this particular nearer image. And the Scatcher theory explained that whenever you are going to look at the nearer object, your ciliary muscles contract, your central journals become more tight, and here you can see this is how the picture of whenever you are looking, the lens become thicker and stupidly curved. So this is how the normal mechanism for the accommodation will be working. Next, presbyopia. Presbyopia is seen in the more than 40 years. The patients are decreased with the accommodation. Okay, these patients will be associated with the decreased accommodation will be seen in this patient. All right, so this patient will be decreased accommodation seen in this patient. How can we correct? By the convex lenses, same like a hypermetropia, because nearer the objects are problem, right? Next, we have the different types of the charts that we are going to use. Snellen chart is the commonly used, where you are going to use the 6 by 6 from the 20 feet, and each letter subtends to the angle of the phi of arc. Next, Landau seeding. This is for the illiterates. Commonly used charts are Snellen, and second most common is the Landau. And same as that, Snellen E chart for the illiterates we are going to use. Next, here you can see these are the visual fields defects. Okay, in the visual field defects, what you have to understand. So there is a tract, neuropathology tract, that we are going to see in this patient. How the vision is coming here. So how the left optic nerve and optic chiasm, optic tract, and lateral geniculate nucleus, optic radiations, and coming to the end of the brainstem. Okay, this is how we are going to look. If the patient is having the defect at the optic nerve, what happens? You are going to see the central scotoma. And if you see the patient is having at the problem at the optic chiasm, you are going to see this is the one bilateral hemiamnopia. And where you are going to see this most commonly, those who are suffering from the pituitary adenoma, because the pituitary adenoma is present at this location only. If it is producing more and more, compressing this the optic chiasm, you are going to see the bilateral hemiamnopia. And by if the both optic nerves which is damaged from the left and right, you are going to see the monocular vision loss. Okay, next, coming to the optic tract damage. Once the optic chiasm, it is going to bifurcate, guys. So if there is a damage in the patients of the optic chiasm, okay, sorry, optic tract, if they have the damage at the optic tract, what happens, these patient will be having the contralateral. So if it is damaged on the right side, the patient will be seeing with the left side of the damage, because here you can see this is where there is a bifurcation is already seen. So contralateral hemiamnopias, homonymous hemiamnopia, that you are going to see in the patients of the at the location of the optic tract, lateral geniculate nucleus, and also at the optic radiation. The effect is still going to be same. Okay. Next, coming to the another picture, here you can see, and these are the defects which will be associated with the macular sparing, and also the contralateral inferior quadranopia and superior quadranopia, all are going to be seen in the nuclear level, and also the optic radiations which will be having the different types of the defects. But at least until here, you have to take note these important points. Next, moving on to the common eye conditions. Here you can see this is the metabolic cataract, seen in which patients, Wilson's disease, because the Descemet's membrane of the cornea will be included here. Okay, this is the metabolic cataract, also known as a famously sunflower cataract. Next, here you can see this is the traumatic cataract, also known as a rosette shaped, because of the patient suffering from the trauma. Next, this is the Christmas tree cataract, seen in the myotonic dystrophy. This is the oil dop cataract, seen in the galactosemia patient, and this is reversible cataract. Next, another condition, due to the trauma, the patient is suffering from the hyphema. Okay, the blood accumulation. Here you can see this is the blood accumulation, and this is the D-shaped pupil seen in the iridodialysis. Again, due to the trauma, the patient is suffering the detachment of the iris from the ciliary body. Next, snowflake cataract seen in the diabetes mellitus because of sorbitol. Okay, because of sorbitol accumulation. Next, senile cataract. Here you can see this is the one of the type of the nuclear. This is the cortical cataract, where you can see the radiations kind of the cataract. And this is the Morgagian cataract and intumescent. Intumescent means complete the fluid is accumulated here. This is the lens is floating. That is the intumescent cataract. And this is the vicious ring. Again, in the patients, those who are suffered from the trauma, there is an imprint of the myotic pupil that you are going to see. This is the vicious ring. Next, moving on to the glaucoma condition, primary open glaucoma and the primary closure glaucoma. So, open glaucoma means the patient is problem in the blockage of the trabecular mesh. So, it has to drain in the trabecular mesh, but this mesh is already blocked. For example, in our sink, if something is lodged, the fluid is going to be accumulated there, right? So, same as here, the trabecular meshwork is blocked here. So when you check the intraocular pressure, it will be very high, more than 21. And on the different types of the diagnostic tonometry, spectrometry, any of you, if you see, there you are going to see loss of neuroretinal rim. Okay, on the optic disc, if you see, there will be optic disc, you are going to also observe the cupping sign, bioneting sign. Bioneting sign means it is going to observe like this. Okay, so this is your optic disc, and where you are going to see the bioneting sign and laminar dot sign. These are the signs that you are going to see on the examination. And the drug of the choice for this patient is the latinoprost. Next, closure glaucoma. Closure glaucoma is going to be that iris is actually pushing. So iris is pushing here. So the glaucoma, the whatever the fluid has to come out, but the blockage here is iris that is going to block. So this is seen in the patients of the closure angle glaucoma. And here you can see, sorry, this is the this is the closure angle glaucoma only. So the patient is iris is pushed forward. So the angle is gets blocked. You are going to see on the examination eclipse sign and walk stride. Walk stride means iris atrophy, anterior subscapular cataract, and fixed mid dilated vertical pupil that you are going to see. Rock hard guy, because this is going to be having more than 40 of intraocular pressure. Very acute condition. Okay, this is the very acute and emergency condition. You are going to treat with the IV mannitol and iridotomy. Okay, next moving on to the anti-glaucoma drugs. First, the prostaglandin drugs. Examples are latinoprost, bimatoprost. What it is going to do, it will increase the uveoscleral outflow because there is a trabecular meshwork problem. So if trabecular meshwork is problem, then another minor pathway, that is the uveoscleral pathway. You have to clear that. That is the how latinoprost is going to work. And the side effects, iris pigmentation, eyelash growth, conjunctival hyperemia, uveitis, and cystoid macular edema you are going to see. Next, beta blockers, and here the topical timolol is given for this patient. It will decrease the aqueous humor production by blocking the beta receptors in the ciliary body. So beta blockers, what it is going to do, it will decrease the production itself. When there is a blockage, you better stop producing the fluid, right? You better throwing more water, you can stop that. So that's how beta blockers is working here. But what is the side effects associated? Blepharoconjunctivitis, blockage of nasolacrimal duct, corneal anesthesia, bronchospasm. So beta blockers start with the B, and here you can see bradycardia, blepharoconjunctivitis, blockage of nasolacrimal duct, bronchospasm. Everything is start with the B only. Side effects. Corneal anesthesia. Remember this way, B B B. So like a BBC channel. Blepharoconjunctivitis, blockage of the nasolacrimal duct, and corneal anesthesia. Next, alpha 2 agonist. Examples are brimonidine and apraclonidine. It will decrease the aqueous humor and also increase the trabecular outflow. And side effects are drowsiness, depression, apnea. Why these symptoms are seen? Because this is going to cross the blood-brain barrier. So, if you see this patient in the children, you should not give this drug. It can cause drowsiness, depression, apnea, eyelid retraction, follicular allergic conjunctivitis. Next, carbonic anhydrase drugs. You have the two important. Dorzolamide is a topical, acidozolamide oral drug. It will decrease the aqueous humor production. Causes are GI upset, kidney stones, metabolic acidosis, paresthesia. Next, cholinergic agents, which you are myotics, pilocarpine, it will increase the trabecular outflow, and brow ache. Okay, eyebrow ache, meiosis, blurred vision, retinal detachment is very rarely seen in this patient. Next, rho kinase inhibitors, natrasudil, it will also increase the trabecular outflow, decreases the episcleral pressure, and causes the conjunctival hyperemia and corneal verticillata. Next, moving on to the uveitis, second most layer, and it is divided into the anterior uveitis, intermediate, and the posterior. So anterior uveitis is included the iris and also pars plicata. So it will cause the iridocyclitis, same as the inflammation only. So here you can see this is a mutton fat. This picture here you can see this is the mutton fat precipitates that you are going to see if there is an inflammation near the iris. Okay, this is the granulomatous type. Next, intermediate type. Intermediate type, it is going to inflame the pars plana, ciliary body, one of the structure. It will show the snow banking. Here you can see this is the snow banking appearance that you are going to see. Next, inflammation of the innermost choroid and retina. It will cause the chorioretinitis. Shows the headlight fog appearances seen in the patients of the toxoplasmosis. Next, sympathetic ophthalmitis. This is a very rare condition and bilateral granulomatous panuveitis. That means anterior, posterior, and intermediate. All the layers are included in this patient. It is associated most commonly with the trauma. Okay, and what happens? Sympathetic ophthalmia means, for example, one eye is normal. Okay, but one eye have the trauma. So over the time, this what it is going to do? It is going to affect the other eye. So this is like a sympathy. If it is a damage, you also have to get damage like that. So sympathetic ophthalmia means like that. So the patient having the injury in one eye, sympathizing eye is going to develop the inflammation, right? That is what you are going to see in the sympathetic ophthalmology. Dull and noid, nodules, mutton fat, keratic precipitates, all you are going to see. If it is not treated early, you have to remove the eye whichever is causing the problem to the normal eye. Next, coming to the retina, important topic, diabetic retinopathy. This is the most common cause for the diabetes patient. And what happens here? The main cause is loss of pericytes. For example, this is your blood vessel. So there is contents of the endothelium. And if there is a gap between this gap is known as a pericyte. Okay. So if these pericytes are lost, so there will be more gap, right? So the proper flow will be interrupted. So which will be causing the inflammation in the diabetes retinopathy. Okay. And what is the classification? Proliferative, neovascularization, non-proliferative, microaneurysm, hemorrhages, exudative, cotton wool spot. Here you can see this is the proliferative. New blood vessels are arising. Okay. This is very severe. If the non-proliferative is not treated early, it is going to develop into the proliferative type. Next, what is the drug of the choice for this patient? If you are already severe condition, you have to give the anti-VEGF drugs. What are the one of the example? Ranvi. Remember this start with the Ranizumab that you are going to give for this patient. Monoclonal antibody, anti-epithelial growth factors that you are going to give. Next. Moving on to the hypersensitive retinopathy, the classification is a Keith-Wagner classification. Grade 1 arteriolar attenuation. So that means arteries is going to spastic. G2 Salus sign, G3 copper wiring, and G4 papilledema and silver wiring will be seen in this patient. Next, moving on to the another important topic, retinal detachment. Rhegmatogenous, most common overall. This is the most common overall. Next, rhegmatogenous, the most common cause is the high myopia or aging patients, trauma and previous cataract surgery. These are the causes. Second most common, tractional type. In this patient, this is due to diabetes, most common cause, or the prematurity of the retinopathy in the children. Next, sickle cell retinopathy or the retinal cell, retinal vein occlusion. Next, exudative type. It is a very rare condition associated with the inflammatory conditions or the tumors like melanoma metastasis will be also seen. Next, how you are going to see the symptoms. Same patients will be, every patient will be having the same symptoms, guys. Curtain falling, curtain falling, and curtain falling. But the difference here is sudden loss and painless vision of the loss will be seen in the patients of the rhegmatogenous. And in the patients of the tractional, it is a gradual vision loss. And again, the sudden painless loss of the vision seen in the exudative. But in the exudative, on the examination, you are going to see the fluid. So that is the difference. You have to differentiate from this condition. Next, this is the retinal artery occlusion. This is the retinal vein occlusion. Retinal artery occlusion, you are going to see this beautiful appearances, cherry red spot. And on the vein occlusion, you are going to see the splashed tomato appearances. Okay, complete splashed tomato appearances you are going to see. Next, cherry red spot, most commonly seen in the cryo and trauma and Tay-Sachs disease. Remaining all also you are going to see, but most common in the artery occlusion, trauma, and Tay-Sachs disease. Next, moving on to the retinoblastoma, most common intraocular malignancy in the children, causes the retinal neuroblastic cells. Okay, the origin is unilateral cat's eye reflex. You are going to see this is due to RB1 gene mutation on the 13th short chromosome. Next, it is going to use the two-hit hypothesis. Okay, like a sporadic. If the first generation is involved, second will be skipped. Again, in the third generation, it is going to hit. So here, cat eye reflex or the white pupillary reflex, leukocoria is common symptom in this patient also. This is the cat eye reflex you are going to see. Strabismus, secondary glaucoma with the ophthalmos and biopsy, you are going to see this sign. This is the biopsy sign you are going to see. What they are known as Flexner Wintersteiner rosettes you are going to see. And enucleation chemotherapy is given with the carboplatin, etoposide and vincristine. Next, optic neuritis and the papilledema. Optic neuritis is the most common presentation and most common cause for this patient is the multiple sclerosis is the most common. And importantly, you have to know that it is going to show the Marcus gun pupil and also Untoff phenomena, Pulfrich sign, and also color blindness. All this will be associated same as the multiple sclerosis. Next, papilledema, this is associated with the increased intracranial pressure. Okay, so this is how the edema will be seen and enlargement of the blind spot and also the patient will be having the blurred disc margins, but vision is normal. Next, blowout fracture. This is the weak, right? The floor is going to involve more teardrop sign you are going to see. Okay, this is the location. Teardrop sign you are going to see. Next, bacterial conjunctivitis. For the mucopurulent, most common cause is the Staph aureus. Purulent conjunctivitis, gonorrhea. This is due to STD. And angular conjunctivitis due to Moraxella. Next, vernal conjunctivitis associated with the hypersensitivity type 1, ropey discharge, and especially boys and in the spring season. Okay, this is how the patients, those who are suffering from the vernal conjunctivitis, you are going to see. And this is the Horner Tarnot spots. Last year question, this vernal conjunctivitis or spring cataract, we can say. Next, trachoma. This is due to chlamydia. ABC serotypes, and you are going to see the sago grain follicles. These are the sago grain follicles you are going to see. Arts line. Okay, this is the arts line that you are observed, and Herbert pits. Okay, there is a black color spots, right? These are the Herbert pits, and Horner tantro dots, white color. Okay, this is the difference between these two. Next, safe procedure we are going to follow. Surgery, antibiotics, facial cleanliness, and environment improvement that should be done for this patient. Vitamin A deficiency, the classification given XN for the night blindness, X1 conjunctival xerosis, X1B bitote spots. This is the most specific sign. This is the first symptom. Okay, first symptom. This is the first sign that you are going to see. Corneal xerosis X2, X3A is going to be less than 1/3 of the cornea ulceration. X3B more than 1/3 of the cornea ulceration. XS scarring, XF fundus inclusion. And how you are going to treat? This is given as a day 1 and also repeat again on the day 14 as per the age group. Less than 6 months, 50,000 international units, 6 to 11 months, 1 lakh units, more than 12 months, 2 lakh units. Next, herpes keratitis. You are going to see this dendritic ulcer you are going to see. If this dendritic ulcer is also progressed, geographic ulcer you are going to see. Drug of the choice is 3% acyclovir. Acanthamoeba, most commonly due to Acanthamoeba species and will cause the painful. And what is the cause here? Contact lens plus dirty water. Okay, contact lens plus dirty water. Then it is Acanthamoeba. And a ring shaped, here you can see this is the ring shape you are going to see. And the drug of the choice is polyhexamethylene bigonal. Chalazion, you are going to see this is how the chalazion will be presented, guys. And chalazion is most commonly due to meibomian glands inflammation. Okay, surgery is the choice. Sty, hardiolum, and it will cause the painful swelling, most commonly due to Staph aureus infection, and it will include the Zeiss gland. Hot compression is enough. Keratoconus is a localized protrusion of the cornea within the thinning. So this is how keratoconus will be seen. Munsus sign. This sign is known as a Munson sign. Okay, next, moving on to the pterygium. It is here you can see this is the pterygium. Classic degeneration of the conjunctiva. Especially it is going to show on the nasal side. Stalker's line is also seen in this patient. How we are going to treat this patient? With the help of the graft placement that you are going to use. Pingvacula, this is most commonly conjunctival degeneration associated with the TB positive patient. Okay, this is how the normal condition, some of the abnormal pathological conditions of the eye. So next we are going to move on to the squint. Before we see the squint, I want you guys to understand about the extraocular muscles. So we have how many extraocular muscles, guys? Total six extraocular muscles. In these 6 extraocular muscles, there is a different types of the nerve is going to be supply this. First, what are the nerves we have? Third cranial nerve, fourth cranial nerve, and sixth cranial nerve. Total 6 extraocular muscles. So all muscles are all muscles are supplied by the third cranial nerve except SO, superior oblique, and lateral rectus. So how can you remember this is all muscles are supplied by third cranial nerve except LR6 and SO4. Okay, that is how you have to remember All cranial nerves are supplied by the third cranial nerve except SO4 and LR6. Okay, that is. Next, coming to the mechanism of action for the each muscle. Medial rectus, it is going to cause the adduction. Lateral rectus is going to cause the abduction. Move away from the central line. Next, superior rectus, it is going to important for the elevation, right? And inferior rectus for the depression. So always remember that these rectal muscles all are going to be straight. Okay. So opposite to that, superior oblique is going to cause the depression. Okay, it is going to cause the depression. And inferior oblique is going to cause the elevation. Okay. So this is the mechanism that you have to understand. Oblique means going to convert their pathway. Rectus straight and their action is also straight. Okay. That is the thing that you have to remember. Next, we have the antagonist muscle. So what does mean by the antagonist muscle? There is a opposite action is seen in the same eye. So the muscles is going to show the opposite action in same eye. Okay, this is seen in the antagonist. Next, agonist. So muscles is going to show the same action. Okay, same action in same eye. So we'll understand what are the examples. For example, if you see the antagonist, muscles opposite the action in the same eye. For example, lateral rectus abduction, medial rectus is going to be adduction. So same eye, but the different direction by these muscles. Next, here you can see muscles show the same action in the same eye. For example, superior rectus is going to show the elevation and inferior oblique is also going to show the same action, elevation. That is how we have to see the muscle same action in the same eye and different. Next, we have the yoke muscles. Okay, yoke muscles. What does mean by the yoke muscles? Yoke muscles is one muscle from each eye helps to look in the same direction. So the direction is going to be say by the version. Okay, version movement is seen by these muscles. For example, right medial rectus is going to which direction, guys? It is going to give the towards the nasal side, right? It is going to move on to the nasal side. And left side lateral rectus, it is going to move on to the temporal side. So these both are looking at left side, right? So here you can see this is the picture. So here the eye and here the eye. So they are looking in this direction. So this is what the yoke muscles. For example, this side lateral rectus is looking at here and abductor here. Adductor, the medial rectus is looking this side. So this is the direction that is going to decide. Okay, these are known as a version movements. Next, we will move on to the squint part. Okay. Oh, in the squint, you have the first paralytic squint. What is this paralytic squint? The cranial nerve palsy. So the third cranial nerve palsy is going to show the levator palpebral superior rectus. That is also going to have the cranial nerve palsy. So for this, there is a symptom of ptosis you are going to see. And all the extraocular muscles are going to be affected. So that properly, if you see these patients, is going to show what kind of symptoms you are going to see, guys. Basically, the patient will be suffering from the ptosis and also hypotrophia downwards and exotrophia outwards and also mydriasis. Okay, these are the defects that you are going to see. So the diplopia that you are going to see is the downside and outward. So this is in the down direction and going outside, which is called as a crossed diplopia. This is known as a crossed diplopia. Next, right fourth cranial nerve palsy. So fourth cranial nerve means only superior oblique is involved. So if it is only involves the superior oblique, it will be defecting for the extortion and also hypertrophia. That is will be seen in this patient. How can you identify? This is actually, if you see, this is the right side of the eye, this is the left side of the eye. So how it is going in the direction extorsion and hypertropia. So the patient is going to show the contralateral head tilt. You are going to see the contralateral head tilt will be seen in this patient, and chin depression because he has to look down because it is going upward. So chin lift and contralateral head tilt will be seen in this patient. Next, sixth cranial nerve palsy. It is the lateral recti muscle that is damaged here. The patient will be showing the esotropia. This is known as a uncrossed diplopia. This is going to be uncrossed diplopia, and the patient will be showing the ipsilateral facial turn. Ipsilateral facial turn will be seen with this patient. This is the cranial nerve palsy. Next, some of the important tests. This is the Hirschsprung test, which will be used for the manifesting the squintantropia, and Prince bar cover test. Here you can see this is the cover and uncover test that we are going to look for the what is the degree of the tropia. Next, cover uncover test. This is to latent squint, or the squint is present but it is not diagnosed, only diagnosed upon the test, that is the cover and uncover. This is the Modox rod test. Again, for the phobia, we are going to look after. Okay. Next, I want you guys to know about the some of the important tests. Okay. So here, I'm going to write the important test. What are the importance of the test that you have to take note? First, spectroscopy. So spectroscopy. So spectroscopy that we are going to use for the patient's endothelium. Okay. Endothelium of the cornea. You are going to look for the spectroscopy. Right. Next, tonometry. Tonometry is important to measure the, it is important to measure the IOP. Right. Next, we also have the topography. So topography is going to examine the corneal surface. Okay, it is going to examine the corneal surface. Next, pachymetry. Pachymetry is going to measure the corneal thickness. It is going to measure the corneal thickness. Next, keratometry. Keratometry. So this is important for the corneal curvature. Okay, corneal curvature. So remember this way. K for keratometry, K for curvature. Okay. Next, another one we are going to use is the slit lamp, right? So slit lamp is for the lens layers. Lens layers you are going to examine for the slit lamp. Next, skimmer test. Skimmer test is for the eye dryness. You are going to look the eye dryness and tears. That is for the skimmer test. These are the important tests that we are going to use in the ophthalmology settings. Okay. So this is the ophthalmology rapid revision, guys. Tomorrow I'm going to upload the surgery, and also if we have the time, anatomy images and the pathology images also we are going to upload. So until then, please be prepared well for the upcoming examination. All the best and give your best. Don't forget to watch the Sureshot topics. Okay. Until then, see you guys. Bye bye. Whoever is new to this channel, please do subscribe and share with your friends. Thank you.